Welcome to those of you that are joining us. We are going to get started in just a few minutes. In the meantime, please feel free to introduce yourselves in the chat. Just scroll down and make sure you select everyone when you use the chat function. We also have this housekeeping slide up with just a few things to remember. So your cameras and microphones are disabled, so please use the chat function for any questions, comments, or support. And be sure, again, to select everyone from the dropdown when typing into the chat. You can also place your questions in the Q&A function as well. And there's going to be 10 to 15 minutes at the end of the presentation for a Q&A. If you're participating today to receive CME or CU credits, you'll need to attend for 45 minutes or more to receive your certificate. And all participants who would like to receive credit will need to complete the evaluation survey at the end of the session. And we will put that in the chat at the end of the session and also send it to you in an email following the session. And CME and CU certificates will be sent out via email by October 16th, along with a link to the recording for today's session, slides, and related resources. And all of these materials will also be put on our website in the BHIPP Mental Health Crisis Training Archive. So again, we will get started in just a few minutes. Thank you. All right, it looks like it is 12 o'clock, so we are going to get started. Welcome, everyone, and thank you for joining us today. My name is Lily Stavisky, and I'm a part of the BHIPP team. I will be introducing our presenter for today and facilitating our Q&A at the end of the session. For those of you that are unfamiliar with BHIPP, I'd like to provide some information about our program. So Maryland Behavioral Health Integration and Pediatric Primary Care, or BHIPP, is a child psychiatry access program that supports the ability of pediatric primary care providers and emergency medicine professionals to address and manage mental health concerns. BHIPP is a free statewide program that offers telephone consultation, resource and referral networking, telemental health services, and training and educational opportunities. And the BHIPP consultation warm line is staffed by a team of child mental health specialists, and it's available Monday through Friday from 9 a.m. to 5 p.m. And our phone number and website will be placed in the chat for you. It is my pleasure to introduce today's BHIPP mental health crisis training, Non-pharmacological approaches to managing disruptive behavior in young children, presented by Dr. Amy Benincourt. Dr. Amy Benincourt is a clinical child psychologist and assistant professor in the Johns Hopkins School of Medicine, Department of Psychiatry and Behavioral Sciences, with joint faculty appointments in the Johns Hopkins School of Public Health and Nursing. She's also the Director of Research and Evaluation for BHIPP. Dr. Benincourt's research focuses on the prevention and treatment of pediatric mental health problems in children and adolescents. And clinically, Dr. Benincourt's focus is on the prevention and treatment of disruptive behavior problems in young children ages 2 to 8 years old, with a particular focus on parenting interventions. We are very grateful to have you here today, Dr. Benincourt, and thank you so much for sharing your expertise with us during this session, and I will hand it over to you.
Awesome. Thank you, Lily. Let me just pull up my slides. Can you see those okay?
Yes, we can.
Awesome. Well, I'm really excited to be here with you all today to talk about a topic that, as you could tell from what Lily mentioned, is really an important part of the work that I do. So I'm going to just get right into it. Lily already talked about what BHIPP is, so here's just a little slide to see kind of our overview, and we're so glad that you're all here to be part of this training. And BHIPP is a partnership among a number of different universities, and so I just want to acknowledge our partners and our funders, which include both the Health Resources and Services Administration as well as the Behavioral Health Administration in our state. Okay. And I have no disclosures to make. All right. So today, by the end of this lecture or webinar, you should be able to identify at least 2 potential underlying mental health conditions that can contribute to disruptive behavior problems in young children. Understand why the use of suspensions or expulsions, or what we're kind of broadly call exclusionary discipline in early childhood settings as an intervention for disruptive behavior problems, can be problematic. And to be able to explain some evidence-based approaches to managing disruptive behavior problems at home and in early childhood education settings. I want to start with just a few case examples because one of the things that I want to highlight is that the reasons for what we see outwardly, the disruptive behavior, can be multi-determined. So in this first case, none of these are the real names of children, just want to declare that. So this is Zion. Zion is a 3-year-old boy who presents with the following history. There's no known family history of mental health problems. He has delayed speech, currently speaks somewhere between 20 and 25 words and speaks only in 1-word phrases. He experiences frequent tantrums when he's told no, when he's told he can't have something he wants, when he's asked to transition from a preferred activity to a non-preferred activity, and when he's trying to communicate with adults and they aren't understanding him. And these tantrums can include hitting, biting, throwing things, screaming, and crying. He was asked to leave one previous daycare due to this behavior and is now in his 2nd daycare setting. And he has non-compliance with adult directions both at home and when he was in daycare. And he's also often described as having a very high level of activity or always being on the move. So you can start to think about some potential reasons that might underlie this. Our second case example is Sam. Sam is a 5-year-old boy who presents with the following history. So he was initially receiving early care at home with a relative and no other children. He started his first daycare relatively abruptly at age 3 when his relative could no longer take care of him during the day. And some initial things that we noticed in daycare is he struggled with sharing because he really hadn't had to do that before. His behavior was generally okay, but over time, disruptive behaviors began to emerge, especially after there was a transition in the daycare staff. So, really, a change in the relationships with the people that he knew, so to people that he was less familiar with. And his disruptive behaviors included tantrums, aggression, non-compliance throughout the day, but a particular sticking point was non-compliance during nap time. And this behavior escalation resulted in him being asked to leave the daycare. Then he returned home for a couple months while his mom tried to identify a second daycare. Then he started at that daycare and was asked to leave after 3 days following some disruptive behaviors during nap time and verbal aggression towards a peer. He also experienced ongoing peer difficulties. Really, he preferred to control activities and he struggled with turn taking, again, because he didn't have much prior experience with it. He also has some troubles falling asleep at night. He can fall asleep as long as he's sleeping in bed next to his parent or that his parent is sleeping with him. But when she tried to sleep by herself and have him in his own room, that did not work. He also has a history of some adverse childhood experiences, including an unexpected move to a new home and an unexpected loss of a grandparent. And his tantrums are triggered by being separated from his mother, transitions to non-preferred activities, unexpected transitions, and you can see some of those in his history, being told no or having a limit set, and engaging in activities that he has fears of. So he really tries to avoid doing that. And he has verbalized some fears and nightmares about something bad happening to his mom when he's not with her. And then our last case example is Matt. Matt is a 4-year-old boy who presents with the following history. He has some speech delays. He said his first words around 12 months, but he's still struggling to speak phrases. He has significant difficulty falling asleep. He'll lay down to sleep and then get back up and run around the house for about an hour before he'll settle again to go to sleep, which is really disruptive, not just for his own sleep, but for the sleep routines in the home. He's also a very picky eater and he'll become really upset during meal times when he's presented with foods he doesn't like. His tantrums occur when he's told no, when he needs to transition to non-preferred activities, during meal times, as I mentioned, and also in response to changes in routine. Look like throwing himself on the floor, screaming, crying, and at times he has hit his head on the floor. A family history is significant for ADHD, anxiety, and mood disorders, and he has a recent diagnosis of autism and is not currently in a structured educational setting. So one common theme, well, 2 common themes across those cases, all boys, and we'll talk some about that, and all having some type of tantruming. But as you can see, there's some differences in kind of their experiences and potentially the triggers underlying those disruptive behaviors. So we're going to talk a little more about disruptive behaviors. So these are just some global numbers among children in the US, and some of this data is drawn from the National Survey of Children's Health. I think I'm getting that right or close to right. 23% of children have a mental health, emotional, developmental, or behavioral disorder. 18% of children in this wide age group, again, this is not just young children, have a developmental disability. 45% of children have experienced at least one adverse childhood experience, and 18% have experienced 2 or more of those adverse childhood experiences. And all of these difficulties can display as disruptive behaviors. So I want to talk about something that really we face as providers and professionals in various settings trying to make sense of children's disruptive behavior. It's called diagnostic overshadowing. And this is the tendency to miss an underlying diagnosis by attributing some of the prominent symptoms to behavioral diagnoses. When this happens, there's a failure to really consider other factors or explanations that may delay accurate diagnosis or identification of other comorbid problems. Disruptive behavior problems in early childhood could be a sign of typical development. They could also be a sign of a developmental disability, a mental health or emotional disorder, trauma exposure, or a combination of one or more of these. That's what makes this so tricky. All three cases that I presented had temper tantrums. And temper tantrums in young children can be due to mental health or emotional difficulties like anxiety and trauma, developmental difficulties like developmental delays, speech delays, hearing impairment, or autism, and as well as behavioral difficulties could be due to sleep or lack thereof, could be early signs of ADHD, or simply could be age-appropriate toddler behavior. Yeah, I include this picture here of this child falling out in the grocery store. Definitely a common concern that I hear parents talk about what to do when my child's having a tantrum in public. So again, I think the important thing to remember is that these temper tantrums can be triggered or underlied by multiple different problems. 30 to 40% of children with any developmental disabilities have co-occurring behavioral and emotional disorders. So this chart's a little busy, but I'll just want to walk through this. So among youth who have an intellectual disability, 30 to 50% of them have any type of mental health disorder. 30% have ADHD, somewhere between 7 and 34% have anxiety, 3 to 5% have depression, and somewhere between 3 and 21% may have disruptive behavior disorder. So lots of potential comorbid conditions. We look at a similar pattern when we look at these things among youth diagnosed with autism. The majority of youth have, in this sample that was used here, also had another mental health disorder. 59% had ADHD, a range being between 18 and 66% had anxiety, 15% with depression, and just under 30% with disruptive behavior disorders. And then looking among youth with developmental language disorders, 42% had some type of mental health disorder, and 16 to 35% had ADHD. So you can see that these developmental diagnoses are frequently comorbid with a range of mental health concerns, but particularly there's more that we could explore, but these really are the most common comorbidities here. So now I want to transition, and now that we sort of set the stage about this problem, I want to transition and talk a little bit about disruptive behavior and exclusionary discipline. Okay, so I want to take you just a little bit back, not really something we talk much about anymore, but zero tolerance policies first gained popularity in the 1980s and 90s. Many people, the thinking really at that time was that strict and inflexible policies would result in fairer discipline. But what ended up happening is that the racial discipline gap got wider. In the 1970s, a Black child was twice as likely to be suspended as a white child. Today, and we're going to look at some more statistics on this, a Black child is nearly 4 times as likely to be suspended, even a preschool child. The other hope with zero tolerance policies was that they would make schools calmer and safer. But researchers say that didn't happen either. An American Psychological Association task force issued a report on zero tolerance. This is some years back now, but still relevant to discuss, that said rather than reducing the likelihood of disruption, school suspension in general appears to predict higher future rates of misbehavior and suspensions among students who are suspended. So really, that's the opposite of what we're trying to have happen. And the other thing is that research shows that exclusionary discipline increases the likelihood of negative outcomes. So first we have this increased likelihood of future disruptive behavior problems, and then other negative outcomes like academic failure, dropping out of high school, and criminal justice system involvement. There's some national data on rates of exclusionary discipline among young children. And so as you can see from this chart, this is about among young kids, about 1.4% were asked, their parent was asked to pick them up early from school or their early childhood setting on one or more days. 0.6% were kept home for one full day or more. 0.2% were expelled. Now, those, in the grand scheme of things, those numbers, those proportions are pretty low, but they're still higher than they absolutely should be. Just pull all my animation out here. So preschool children are expelled at higher rates than K through 12 students. Let's just sit with that for a minute. And 4-year-olds are expelled at higher rates than 3-year-olds. The majority of preschool children who are suspended or expelled are male. Black children account for nearly 50% of public preschool suspensions, and they're twice as likely to be expelled as Latino and white children. Now, there's a range of factors, and we continue to study this problem and learn more. There's a range of factors associated with higher rates of suspensions and expulsions. These include program factors like the class size, child-teacher ratios, availability of additional support staff, as well as teacher job stress, teacher mental health, burnout, all things that, especially going through the pandemic and now where things are, just trying to manage and figure out how to make school feel normal and safe. And there's lots of different priorities being thrown at our teachers, so lots for them to carry. And obviously disruptive behavior rests on top of all of that. This is some slightly older data now, but I think it's still relevant to talk about. So this is data from Maryland, from the state of Maryland across all school districts. So Maryland had an effort to cut the use of exclusionary discipline practices, and they were really able to do so by half. So 8.7% of all students in Maryland public schools, kindergarten through 12th, received an out-of-school suspension or expulsion in 2005, 2006. By 2015, 2016, 4.3% of all students received an out-of-school suspension or expulsion. However, when we break this data down into student groups, it becomes clear that the experience of individual student groups varies widely. So you can see in this figure, for example, that 8.1% of African American students and 10.1% of students with disabilities received an out-of-school suspension or expulsion by that 2015-2016 year. This compares to just 2.3% of white students and 3.6% of students without disabilities. So while the use of exclusionary discipline has decreased overall for all students, when out-of-school suspensions and expulsions are used, the data still demonstrate that students of color and students with disabilities are still more likely to be removed from school. So in taking some of this data into consideration, the state has tried to make some reforms. In 2014, there were regulations put in place to create a more positive school environment and keep students in school and learning. These new regulations standardize and minimize the length of student removals, establish a uniform appeal timeline for those removals, specify the minimal education services schools must provide to students who receive out-of-school suspensions or expulsions, and required the collection of data on arrest data, school-based arrest data, to understand kind of more about what is happening when students are suspended or expelled. And then also required the establishment of a process for identifying and eliminating the disproportionate impact of school discipline policies on students of color and students with disabilities. Now, the rationale for these changes was really to shift towards a rehabilitative approach to school discipline, with the idea that time out of school increased the chances of poor academic performance, grade retention, and school dropout, and potential negative life outcomes in the long term, like criminal justice system involvement, unemployment, and poverty. And two, that disciplinary consequences really should serve educational purposes rather than just being used for punishment. On the heels of those reforms was a very specific point of policy for children, for younger children, children in pre-K through grade 2. So beginning in 2017, school systems were prohibited from suspending or expelling children in this age group, with a couple exceptions. Expulsions were only allowed if the behavior that led to the expulsion was something that's required by federal law, such as bringing a firearm to school. And suspensions for up to 5 days per incident were allowed if the school administration, in consultation with a mental health professional, determined that there's imminent harm to staff or students that cannot be reduced through other interventions and supports that allow the student to stay in school. This change is really based on some initial work done by Dr. Gilliam, really on the harms of expelling, the frequency and the harms of expelling children in pre-K. So now I just want to make a couple points about what is appropriate exclusion and what's sort of inappropriate. So exclusion is removal of a student to a supervised area for a limited period of time during which that student has the ability and the opportunity to regain self-control. They're not receiving any instruction, including special instruction related services or supports, but really is meant to help them to re-regulate. This type of exclusion is indicated when the student's behavior is interfering with their learning, when other students might need protection from this student, when the student themselves requests it, or when it's supported by a behavioral intervention plan. It's also important to keep in mind that exclusion cannot be used as a punishment, and that the school needs to be able to provide the student with an explanation of what behavior resulted in their exclusion, as well as instructions on what behavior is required to be able to return to the learning environment. And this needs to be done in developmentally appropriate terms so the child can understand. But even though we had these best intentions of limiting exclusionary discipline, the initial rollout didn't also include sufficient supports for schools to be able to provide alternative supports to students. So some of the unintended consequences of limiting exclusionary discipline really include the increased use of inappropriate interventions. These can be things like calling the parent to pick the child up before the end of the school day, emergency petitions when those were not necessary, or in-school removal from the classroom, such as keeping the child in the front office for extended periods of time. So it's important to clarify that schools who send children home before the school day ends or ask a parent to keep the child home an extra day are engaged in what's called illegal exclusion, unless the formal suspension rules are applied, such as the school must send home formal papers and tell the child and family why the child is suspended and for how long. So now I want to transition, now that we've talked some about the etiology of disruptive behaviors, as well as some of the challenges that happen with disruptive behavior in trying to intervene with disruptive behavior in the school setting. I want to talk some about 2 different types of treatment for disruptive behaviors. First, I'm going to talk specifically about behavior management training, and then I'm going to talk about 2 frameworks that are used in educational settings to help address disruptive behaviors. So behavior management training is a treatment modality for improving adult-child relationships and reducing behavior problems that are common in young children. And you'll see on this list, there's that tantrums behavior that we've already talked quite a bit about, as well as noncompliance, aggression, and school avoidance. This intervention can be used to both prevent and treat child behavior problems. And it's really based on the underlying assumption that adults can be taught to be the change agents for children's behavioral difficulties by changing their own behavior. Behavior management programs can be helpful both for shaping behavior at home as well as in the educational setting. And so for the purposes of the rest of this talk, I'm going to focus some, the strategies I'm going to talk about next will focus some on strategies that are really common in parent management training interventions, but they're also common in kind of more global behavior management interventions. First, I want to make this point that behavior management training has been shown pretty consistently to be an effective approach for addressing disruptive behavior problems. It's really the first line treatment for preschoolers with ADHD, and it's also a well-established treatment for oppositional defiant disorder and conduct disorder for children less than 13 years old. Behavior management training programs are guided by social learning theory, which posits that adults are powerful models and reinforcers of children's behaviors, both positive and negative behaviors. So within this theory is the coercive process model. And this model suggests that adults and children can unknowingly reinforce the wrong behaviors in one another. So let's take a common scenario where a child has a tantrum in class when they're asked to transition to reading time. In response, the child is taken to the office and therefore misses the reading activity that they didn't want to do anyway, which just taught them that they can tantrum to get out of the things they don't want to do. The second piece of this model is that children inadvertently reinforce undesired behaviors in adults. For example, we have a situation where a child does not put her toys away after her parent has asked her multiple times to do so. The parent now threatens the child with a spanking, and the child puts her toys away. What's happened here is that this child has thus reinforced the parent to escalate the consequences in order to get the child to comply. But what parent management training and behavior management training programs help adults to do is to stop this cycle through the skillful use of their attention, behavior, words, and affect. So we're going to talk more about what that looks like. There are literally hundreds of evidence-based behavior management programs. They're all based on a similar underlying theory, which I just talked about, and they cover similar types of strategies, really focused both on positive reinforcement to strengthen the adult-child relationship, as well as limit-setting skills. Many also include a focus on problem-solving skills, managing adult stress, and also include the use of practice assignments, because we know that our behavior doesn't change just by coming to a meeting. We really do need to try these strategies in our lives, in our classrooms, at home, in public, and come back and talk about what's going on so that we can kind of refine how those work. But these programs really focus on strengthening the adult-child relationship before tackling the problematic behaviors, because the theory is if we do that focus more on strengthening the relationship, we'll ultimately need to do less management of the problematic behaviors. So now I want to talk about 5 different positive reinforcement strategies that are common in behavior management training programs. The first is what's called child-centered time. This is the time adults spend with kids focus on what the child wants to do. During this time, the adult follows the child's lead, letting the child pick the activity and decide how they will do it together. This is also sometimes referred to as one-on-one time, and it can be as brief as 10 to 15 minutes a day. This helps the adult-child relationship because it reduces the chances that children will use negative behavior to get the adult's attention. And it also promotes feelings of love, warmth, and a positive sense of self in the child. Related to child-centered time is a second strategy called descriptive commenting. This is often used in the context of that child-centered time. This is a strategy where the adult describes what the child is doing, acting like a sports announcer for the child's actions. So for example, you're turning in circles, now you're jumping up and down, you're climbing up the stairs, now you're sliding down the slide. And this is a useful way for parents to teach children or adults to teach children new things, but without controlling the interaction or overwhelming the child with questions and instructions. We can also use descriptive commenting to label children's feelings. We don't have to be completely accurate about what they're feeling, but we can, as the adult, just observe, it looks like you are really sad right now, or it looks like you're really worried right now. And that helps to both give the child language for how they're feeling and start to help them make those connections. Another strategy that's taught in behavior management training programs is around establishing routines. Routines are behaviors that are regularly practiced, such as brushing your teeth every morning, taking a bath every night, or reading before bed. And routines help children to feel safe and in control of their world because they know what to expect next. Routines can decrease anxiety and behavior problems for that very same reason. And they can also help children who may have executive functioning difficulties in terms of remembering what comes next. Another related strategy is the use of praise. So this is another type of positive reinforcement strategy. So we know, we've already talked about today, that any attention, whether positive or negative, can reinforce a child's behavior. Therefore, it's important to help adults understand that they can use their attention strategically to encourage positive behaviors that they want to see more of. And one way to encourage this specifically is through praise. And praise helps because it gives attention to desirable behaviors, helps to build children's self-esteem and self-confidence, and increases the chances that the child will want to repeat that desired behavior again. Now, there are two types of praise. Both are good. One is slightly better. So labeled praise include positive statements that point out the specific behavior the child did that the adult likes, such as, I like the way you clean up your toys the first time I asked. Or I love how hard you are working to clean up your toys, which gets at the effort and not just the outcome. It's important that these statements stay positive, as mixing them with criticism leaves the child focused more on the thing the adult said that they didn't like than on what they did that the adult liked. The other type of praise is unlabeled praise. These are positive, but sort of more general statements of approval. Good job, nice work, you're such a good boy. They still feel good to the child, but they don't necessarily help transition to changes in behavior because the child's left not knowing exactly what they did to get the praise. So ideally, labeled praise is really more powerful than unlabeled praise, but it does require us to be more attentive and specific in the behaviors that we are going to let our child know that we like. Building from praise, there are some situations where we would say, there's a challenging behavior that the child is trying to master. And by challenging behavior here, I mean a challenging positive behavior that they're trying to do, that praise alone isn't enough reinforcement. So this could be behaviors like staying in their own bed all night, helping with cleanup, getting dressed in the morning, or packing up their stuff to go home for at the end of the school day. So these are all potential behaviors that could be the target of a reward program. And rewards can include tangible rewards like stickers, star charts, earning points towards a desired reward, but they can also be social rewards, staying up later, getting extra time with the parent, playing an extra game. But to be effective, reward programs need to be clear, simple, age appropriate, and ones the adults will be prepared to consistently follow through on. Reward programs help because they really focus the adult's attention specifically on the behavior they want to see more of. And it's our way of acknowledging to the child that we know this is a behavior that's challenging for them. And therefore, we're providing a little bit more incentive or encouragement behind it. But some other types of behaviors that can be used as a target of a reward program might be toilet training if the child's developmentally ready for that, reducing aggression or keeping one's hands to themselves. We already talked about the situation of sleeping in your own bed. So we've talked about some strategies that are really those positive, really trying to give more attention to the behaviors you want to see more of, as well as specific strategies to strengthen the parent-child relationship and to help with kind of overall feelings of safety and security at home. Now we're going to transition and talk a little bit about some effective limit setting strategies, and I'll talk through 5 of these. So the first here, in order to really set limits, the kind of precursor to that is to make sure that we are being clear communicators with the children that we're interacting with. Some colleagues of mine at the school, in the Johns Hopkins School of Nursing, observed hundreds of parents playing with their 2, 3, and 4-year-old children, each for about 15 minutes. And what they found during these 15-minute play sessions, which were free play sessions, the average number of commands parents give their young children is 64. That's more than 4 commands a minute. It's literally impossible for a child to follow so many instructions, and no parent can follow through on that many instructions. So as a result, many children either learn to tune their parents out and ignore their parents' instructions until their parent escalates things to yelling or threatening. But some children are not well regulated enough to tune their parents out and instead become anxious, overwhelmed, and destructive. So for these reasons, it's really important to focus on how we can be as clear of communicators with children as possible. This means reducing the number of instructions that we're giving to only those that are really important, being clear in the instructions that we're giving, and being prepared to follow through on the expectations that are set with that instruction if the child does not follow it. So part of this aspect of a behavior management training program is really first raising awareness to all the ways that we might be communicating that we think are clear, but really could be unclear. So I have some examples here on this slide of do statements. These are really clear, the clearest way that you can communicate because they tell the child what you want them to do. Put your coat on, please put your toys away, turn off the TV now and start your homework. You must get into your car seat, all of those things. But there are a number of examples of ways that we're unclear. These are the most common ways. The first is negative commands. Don't leave your toys out as an example. These are unclear because they tell the child what we don't want them to do, but they'd leave them wondering what it is they're supposed to do. Another common one are question commands. We're all guilty of this because we're trying to be polite. Could you put your toys away? Would you mind helping me do fill in the blank? But the problem with that is that it communicates to the child that following your direction is optional, when in fact, we probably don't mean it that way. Another common unclear command is a chain command. You know, as adults, we can handle multi-step commands and we have lots of different things flowing through our minds at any given time. But children are not able to take in all of that information, especially young children. So a chain command would be, you know, put your shoes on, put your coat on, grab your lunch, grab your backpack, and let's go. A child doesn't have the chance to follow step 1 before you've asked them about step 2, steps 3, and step 4. And so often what happens is the child might end up doing only one of those things or really stopping dead in their tracks and being like, I'm not sure what you want me to do. So the solution really is to slow that down and do steps 1 at a time. The last kind of common example of an unclear command is a critical command. And this can happen, you know, when we've asked and asked and asked our child to do something, or in the school setting, we've asked a child to, you know, clean up or whatever it is multiple times, taking multiple reminders, and we're feeling frustrated, right? And so we add some criticism to that command. stop being lazy and get off the couch. Or how come you don't put your toys away now? How come I have to ask you that 6 times? But what ends up happening is it causes children to feel badly about themselves and angry about being told to do something, and doesn't make them any more likely to do what you're asking. So these are the things to avoid. And instead, we really want to focus on those do statements, giving clear statements about what we want the child to do. And once we've been clear and get with those statements, we have to be prepared to follow through if the child doesn't comply. So I'm going to talk about 2 strategies that can be helpful in this situation. The first is logical consequences. Logical consequences are if-then statements that describe what the adult will do if the child continues the misbehavior. These if-then statements need to include consequences that are logically consistent with the misbehavior, that are immediate or as close in time as possible, and that are age appropriate. For example, if you don't eat your dinner, you won't get dessert. Or if you color on the table, then I'll take the crayons away. Or if you two keep fighting, then you'll both have to go to the office. All of these are what will logically happen if the child continues the misbehavior. And what will happen is something that can happen close in time to the misbehavior. These statements help because they give children a warning of what will happen. They give children control over their choices, and they also reduce the yelling and nagging that can sometimes happen when we become frustrated with non-compliance. But there's a couple other things to keep in mind with these. They are not appropriate for use with children who are developmentally under the age of 2, because they don't yet understand cause and effect relationships. And as adults, we have to be prepared to follow through with the consequence if the misbehavior persists. Otherwise, our statements begin to lose kind of the oomph behind them, the meaning behind them. Another strategy that doesn't focus on a consequence so much, but can also be used to increase compliance, are when-then statements. These are statements that tell the child what they must do in order to get something that the child desires. And then it's up to the child to comply with the original instruction. We sometimes call these win-wins because as the adult, we want the child to do something and we can see that there's something the child wants. So we sort of have maximum leverage. So examples, when you clean up the toys, then you can go to recess. When you say, please, then I will help you. Or when you finish your homework, then you can go outside. It's basically like a mini reward program. They need to do the thing you're asking them to do first, and then they can get the thing that they want. And these are helpful because they establish clear expectations for children while giving them control over their choices. The last behavior management strategy I want to talk about is ignoring. And so ignoring involves not talking to, looking at, or responding to a behavior while it is occurring. But once the misbehavior stops, we need to give our attention right back to the child. Ignoring is easy to say, right? That was a pretty simple explanation, but it's difficult to do well, in part because the behaviors that we're usually trying to ignore are annoying. Whining, tantrums, sometimes cursing can be ignored depending on the situation or the family's values. But all of these things are things that are kind of hard to listen to or kind of be around, right? But really that are done to try to get our attention. This strategy helps manage behavior because it removes our reinforcement of the misbehavior, but it should only be used for misbehaviors that are safe to ignore and should not be used for behaviors that are unsafe or destructive, like running away from an adult or aggression towards others. It's also important to note that, and really keep in mind that initially ignoring a behavior that you previously had given attention to may actually lead the behavior to get worse before it gets better. And that's because the child is sort of upping the ante, not necessarily completely consciously, but they're still trying to get your attention. And so that's just a good thing to anticipate that this, with families who might be using this, that things may get worse before they get better, but that actually means it's working. So I talked some about some specific behavior management strategies. And now I want to transition and talk about two frameworks that are helpful in the context of educational settings to think about how we do various interventions to prevent or address disruptive behavior problems and to promote young children's social emotional development. The first is called the pyramid model. This is a framework of evidence-based practices for promoting young children's healthy social and emotional development. This model helps adults in various early childhood settings to interact with children and to address challenging behaviors that come up. And this is really a tiered, both the models I'm going to talk about are tiered interventions. So tier 1, which is those first two blue layers above the effective workforce, focuses on nurturing and responsive relationships and quality supportive environments. And this level is really all about creating positive relationships and environments for young children. This applies to all children, so it's a universal interventions. Can include strategies to foster positive adult-child relationships, like joining in children's play, engaging in supportive conversations, providing encouragement and praise and feedback to children, teaching rules and expectations for the environment to keep everybody safe, having some structure around transitions, providing clear directions, and providing engaging activities. And you can see some of those behavior management things that I just talked about are kind of contained within some of this first tier of interventions. It also includes strategies to promote family engagement and to educate families about how to promote their children's social and emotional skills. So these interventions in this universal tier are for all children in the setting. But some children may need additional supports. That's where tier 2 comes in. This is targeted social emotional supports. So some children may need some specific instruction. These include instructions and skills like identifying and expressing emotions, building friendship skills, and developing strategies for regulating children's emotions. And then we have tier 3. In tier 3, parents, families, and early care and education providers are encouraged to use a behavior support plan to determine the meaning behind a child's challenging behaviors. This is really individualizing of supports to meet the needs of children who are struggling. In this, interventions provided in this tier are also may involve developing a plan that specifically addresses the triggers and functions of challenging behaviors the child may be experiencing. This model has some initial research behind it that shows evidence of improvements in children's social skills and reductions in challenging behaviors, as well as expulsions from early care and education settings. So definitely promising and addressing outcomes that we really think are going to be critical for children with disruptive behavior problems. A related model, related in the sense that it also involves a pyramid or triangle of sorts, but is for the school age group, is positive behavioral interventions and supports. This is a framework that guides the selection, integration, and implementation of a bunch of evidence-based practices for improving academic and behavioral outcomes for all students. When implemented with fidelity school-wide, universal PBIS really aims to reduce disruptive behavior problems, enhance the school climate, and create safer, more effective schools for all students. And this is accomplished by targeting staff behavior and teaching students agreed upon behavioral expectations, also promoting a shift from reactive punitive practices to support decision-making and the promotion of positive behavior. As you can see here, similar to the other pyramid model, this is a tiered framework. So in tier 1, these are universal strategies or universal prevention because the interventions that are done here are going to meet the needs of all students. And the best universal interventions will address the needs of most, but some students may need a little bit more beyond that. An example of a tier 1 intervention could be a universally implemented social emotional learning program, such as Second Step. In Second Step, children are given instruction in social and emotional learning with units on skills for learning, empathy, emotion management, friendship skills, and problem solving. And there's separate sets of lessons for use in pre-kindergarten all the way through 8th grade. The second tier here, similar again to what I showed in the other model, is referred to as a targeted intervention and is usually appropriate for a smaller portion of students with some risk for disruptive behavior or other difficulties. And the goal of this intervention is to reduce or eliminate this risk. Usually interventions in this tier are short-term, somewhere between 10 and 20 weeks. They might be group-based, and they focus on specific skills. For example, calming strategies can help a child to work through strong emotions. And so when calming strategies are practiced regularly throughout the day, the possibility for their use at a time of anxiety or stress increases. And this could look like a classroom creating a calming corner where students can go to that's equipped with different materials they can help to soothe their distress, emotion dysregulation, and then allow them to return to the educational setting. The goal really of such an intervention like this is to decrease negative affects, stress, and negative behaviors within the classroom, improve social competence and attention, decrease anxiety, and decrease aggression and other social problems. Now, so this between tier 1 and tier 2, most students will get their needs met. But there are a select group of students who still may need more intensive or individualized interventions. The interventions in tier 3 are highly specific. They require frequent monitoring and they are individualized for that student-specific needs. These are interventions that address student behavioral and academic needs that are designed to reduce disruptive behavior problems, improve academics, enhance the school climate, all of these things. And some common tier 3 strategies include things like functional behavioral analysis, behavioral intervention plans, IEPs, and 504 plans. And just a couple notes about what the research says on PBIS. There's quite a robust research base, a lot of which has been conducted in our own state. And this research shows when PBIS is implemented with fidelity, there's improvements in discipline systems and practices, improvements in school climate, student achievement, and student prosocial behavior and emotion regulation, and then reductions in bullying, aggression, and referrals for behavioral support services. And then I've just got a few references for you. These slides will be available on our website. And thank you for your time. And we still have a little bit of time for some questions.
Yes, thank you so much, Dr. Benencourt, for that wonderful presentation. Now we will do the Q&A portion of this session. We do have one question already, or actually a few questions already. First one is, could you please comment on the use of timeouts at home or even at school?
So timeouts, when done well, and that's a really kind of broad term, but when following kind of the specific criteria, can be very effective. And timeouts really are essentially like an extended ignore, because what we're doing is we're removing the child from the situation where the misbehavior occurred, and we're giving the child some time to calm down and get re-regulated and return to that situation. And so they can be very effective and definitely are safe to do at home and in public. In the educational setting, it can be a little tricky because there may be it's certainly in terms of following the steps to a timeout can absolutely be done. But different educational contexts have different rules around whether timeout is something that they're allowed to do or that they agree to do. But we know, and there continues to be good research to support that timeout is an effective strategy for managing misbehaviors. And really, I talked about logical consequences earlier, and timeout is one example of a logical consequence. It can be really effective for as a consequence for aggression or other types of unsafe behaviors where the child really does need to be kind of removed from the interaction or the situation that kind of spurred the disruptive or aggressive behavior, and given that opportunity to kind of resettle and return.
Thank you. Next question would be, how would you recommend handling misbehaving in public settings?
Great question. So misbehaving in public, a lot of the same strategies that can be used to address misbehavior in private can be used in public. I actually work with a parenting program called the Chicago Parent Program. We really spend give a specific attention to helping parents think about how they might use these strategies in public. You can absolutely do a logical consequence in public, but it depends on what the parent is going to be comfortable with. You could do a timeout in public if the parent was able to think ahead of time about where's the timeout going to happen, and to really be clear with the child about what behavior is going to lead to that timeout. You also could use other types of logical consequences, like the removal of a privilege or something like that. So it's certainly they're certainly able to be done in public, but really it is helping the family to really think about what that's going to look like, so they feel prepared, and what are the common triggers for that misbehavior in public, and what do they feel comfortable and able to enact consistently, so the child learns, that no matter where I do this misbehavior, these are the consequences.
Great. Next one is, say a kid 7 years old insists on a tablet instead of a family outing, a few steps. I'm not sure if they would like to expand on that or if you would like to answer.
So I just wanted to look at that again. So they insist on the tablet instead of a family outing. So I think this comes back to thinking about let me back up. If the parent knows that the tablet and transitioning from the tablet could be a trigger for misbehavior, and they also know that they are going to do this outing, then one thing is to think about whether to even introduce the tablet as an option. Because that could, if we know ahead of time, that could potentially lead to disruptive behavior. Some of this is trying to take out some of those triggers if we can. If we can't, and they're having trouble transitioning from the tablet to going on the outing, that's where a logical consequence could be very helpful. If you will not stop playing with your tablet, you're not going to be able to play with it again when we come home. That is a little bit further off for a young child, so we have to be a little bit careful about that. But the point being that you're really setting this limit. If they choose to not follow the direction, which is to get ready to leave the house, then they're going to have the tablet taken away. But it also might speak to the parent or the family wanting to have some specific rules and routines around when tablet time is, or how much time that the child can get access to, so they can kind of help to set some expectations and clear rules around these highly coveted items that we know can be a source of tantruming.
One more question we have is, what strategies can teachers use for students that elope?
That's a really good question. So eloping is certainly one of those behaviors that is an unsafe behavior, right? So we talked about ignoring. No, ignoring is not an option, because really that's a safety concern. So a couple things to think about. If it's the school setting and this is a child who tends to elope, is there somewhere we can help them to go to? Clearly they're having some kind of reaction to the context. They need a space to go to calm down. Can we help get that child, instead of eloping completely, can we help get them safely to an environment where they can have the time to calm down? do they need additional adult support in the context so as not to to help keep them safe and keep them in the context instead of eloping. But we also need to understand probably a bit more about what it is that is triggering the eloping. Is it anxiety driven? Is it avoidance of a task? Maybe the child has an undiagnosed learning disability and they're eloping to get away from a task that's too hard for them. Some of this is also probably gets to how do we learn more, try to understand more about what's leading to the eloping. But I do think, at home, potentially you can also use the, trying to keep all the doors locked and have locks that are out of the child's reach if we're talking about a young child. But those strategies may have limits to how effective they are. So the other pieces we really need to kind of understand more about what is triggering the eloping, and can we also give the child some additional skills and maybe also adult supports to get to a space and calm themselves down. I know that's not the perfect answer, and eloping is definitely a challenging behavior. But I think a combination of both environmental changes as well as teaching the child some skills are probably going to be the best way to address that. I know we had another comment about running away from home, which I think is kind of in a similar vein.
Okay, I think that is all our questions for today. Thank you again for this wonderful presentation, Dr. Benincourt, and to all of our participants in today's session. The recording for today's session, the slides, and a list of related resources will be available on our website next week, and we will also send that to you via email. We will send CME and CEU certificates to participants by October 16th. And please remember to take the survey as you exit, as this is required if you'd like to receive CME or CEU certificate. And please stay tuned for future BHIPP mental health crisis trainings and other BHIPP trainings by following us on LinkedIn, Facebook, or Twitter. And thank you so much again, and I hope everyone has a great rest of their day. Thank you.